Welcome, everyone. My name is Corinne, and I will be your moderator this evening. Dr. Scott Coleman will be our speaker tonight, and he'll be sharing effective tactics and techniques for Class 2 restorations. If you've attended a previous webinar with us, you may have noticed that our in-webinar console has changed, and I would like to highlight some features that will enhance your viewing experience. If you have a question, please type it into the box labeled "Have a Question," and we will answer them live at the end. To talk with other attendees, navigate to your control panel at the bottom of your screen and click the chat icon. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. And lastly, this webinar is sponsored by Kerr Dental. Dr. Coleman, welcome, and thank you for being with us.
Thanks, Corinne. Gosh, it's a pleasure being with you guys tonight. I hope everybody had a great day. I know it's kind of the tail end of my day. So we'll spend some time, hopefully get some little tidbits to you guys and get you on with your evening. There's a ton of stuff. They asked me to put this in there, but basically to give you some idea of who I am, I'm a general dentist. I practice general dentistry 4 days a week. This is my 38th year in practice, and I do everything from fillings to implants, root canals, crowns, a lot of cosmetic stuff, veneers. There's just a lot of stuff that I do. There's a lot of certifications or education, I guess, that I've taken in order just to kind of improve my skill set, really more than anything else. People say, "Oh my gosh, you got 5 fellowships and all these masterships," and that's not really to be impressive to anybody. It's really just my striving to try to do better for my patients. It's kind of the way that I view it anyway, or what I work hard at. Obviously, the opinions that I'm going to give in the next 45 minutes or an hour are basically mine. I don't want you to think that Cavo Kerr or Henry Schein or whatever's the ones that said, "Oh my gosh, I tried that and it didn't work, so I'm going to be mad at Kerr or Schein or somebody." It's like, no. If you're going to try what I'm fixing to show you, great. If you're going to be mad at somebody, be mad at me, not them. Because obviously they're not in the business to dispense any kind of medical advice, and don't want anybody to think that they are. So who am I? I graduated in 1984 from University of Texas Dental Branch. I've been an associate professor there for, probably the last almost 30 years. So I kind of stay in the loop with the academic side. I don't really teach a bunch to the undergraduate, the pre-docs, but I do the postdoctoral programs and enjoy doing that. I've had my own in-house ceramic lab. I started out with 2 ceramicists. I'm down to just 1, but since 1988. So I get kind of geeky with all the materials and, ceramics and bonding agents, and, I kind of wade off into the weeds on that stuff and have for a long time. So there's, I can really relate both to the lab side of stuff, the material side of stuff, as well as to the clinical. I'm a cone beam user, 3D guy since 2012, last 10 years. Certainly that's the way to go. If you're not into the 3D world, you certainly need to shift gears as quick as you can and get there. You'll be amazed at what a better dentist or practitioner that you become whenever you see stuff that you simply can't see in the 2-dimensional world that the 3D world will illuminate for you. CEREC user, big CAD CAM guy. I started with CEREC 2 back in 1996, which honestly was kind of a piece of junk. Within probably a year or 2 after that, all the restorations I'd placed with it, I'd gone in and replaced them. So, kind of start off with a rocky road with those guys, but really stuck with it, got back on it, and have been using CAD CAM, pretty consistently since then, and have been on that journey for a long time. And really, I'm not going to say 100% of my crowns and bridge work are CAD CAM today, because I do have my own lab. So a bunch of my full mouth stuff, my lab still does, but everything else, from anterior veneers to posterior crowns, inlays, bridges, all the implant work. I place all my own implants. I guide all my own implants. I make all my own surgical guides. and restore all of my own implants with CAD/CAM. Obviously, I train people on CAD/CAM, CIRAC. I do Invisalign as well. I'm a mentor at the Spear Center and have been for a while. And I do speak for Sirona, SciCam, Beyond International, and Kerr currently. This is my website, cosmeticdental.com. People, after the end of this, if you have questions or things that I don't answer for you, which I'm sure there will be, don't hesitate to reach out to me. I'll put up at the very end kind of my email and ways to get in contact with me. But cosmeticdental.com is the simplest way to, if you don't remember anything else, just think of that. Get to that website and you can then get to me. So let's talk about, the world in which we live today, disruption. Lord, man, is it not a changing, disruptive current situation on multiple levels? I mean, we can spend hours talking about just how disruptive our lives have been, not only in our profession, but personal lives, political world. I mean, you kind of pick your poison, and it is a crazy place out there right now. Specifically, disruption in the term that we're going to spend the next few minutes talking about is really, things that we've always done or things that we learned in dental school or materials or places or processes that we became very familiar with and comfortable with, and new thinking, new innovations that have come along and disrupt the way that we go about our day-to-day business. I always think about business-related concepts and how it applies directly to dentistry. And I'll never forget, in fact, this always comes to mind when I talk about this. I was doing a lecture in the Boston area and was at the airport, leaving the terminal, going to walk across to get on the rental car shuttle thing, and stopped at the curb to kind of, look both ways so I don't get hit. And it just really kind of hit me upside the head. I looked to the left, and there were probably, 10 or 12 people standing there with their little phones, kind of looking down at their phones. And I'm thinking, golly, what are, with their luggage. And obviously they were waiting for Uber. There wasn't Lyft at the time, so Uber. And when I looked to the right, it was just astounding because there were like 6 or 7 yellow cabs that were just sitting there. Nobody in line to get into a cab. And so I paused and I thought, wow, here's people that really want to get someplace, and they could immediately go and get in a cab and be on their way. But they chose, nope, I'd rather do it on my phone because I want to know exactly where I'm going, who's going to pick me up, what the costs are going to be. And really the disruption term popped into my head. I thought, if I was in the cab business, how disruptive would the ride sharing apps in business be? Completely. What an upside down world it would be if I owned a yellow cab company. Same thing applies, and there's multiple. That's just one example. But when I think about our profession, and as long as I've been practicing, things have dramatically changed. I think about the materials and processes whenever I graduated and passed, the boards and stuff. What was expected of me then versus what I actually in reality do today, and what a dramatic difference. I think of one of the most disruptive things that's just, blatant and descriptive would be, when the removable Align technology came out with their processes of, all of a sudden, instead of in the orthodontic world, instead of using traditional mechanics of wires and brackets and having to see the orthodontist every 3 weeks and going through this whole process of changing that over into a piece of plastic, basically, that the patient can change out themselves, every 2 weeks. And now with Smile Club Direct and all these other guys, but people have kind of even bypassed going to the dentist. Why in the world do that? Just do it yourself at home. Certainly another topic for another day. But the point being is, how disruptive has that technology, how disruptive has that process been in in treating a certain process, in this case, trying to correct your teeth or, realign your teeth from the way that it was, traditionally kind of done and how we were trained, at one point in time to where that is today. I mean, just a dramatic difference. So think about, when I think about everything that I do day in and day out, the technology, whether it's an intraoral camera or CAD CAM or, cone beam or whatever it is, how disruptive has that been in the way that I practice? One of the things that I've always kind of lived by for me is I really am a big fan of, modeling and how does my practice model? What do I do? How can I change with the times? I think back on whenever AIDS came out and, everybody was so deathly afraid of this virus and it was going to kill everybody and dentists in particular. And, we were going to have to treat everybody in hospitals and every patient was going to have their own set of instruments and their own handpiece because of the spread of it. I mean, that's how severe it got into this process that we've just kind of are coming out on the other side of with the coronavirus issues. I mean, just, those kind of things are, change is constant. We constantly have to be aware of that. And what are we going to do in our practices in our day-to-day life, but in our day-to-day practice that is, that we're going to be able to accommodate that or change with that. I think a lot of times it's real simple to get lackadaisical and not really be paying attention to what's going on. And all of a sudden you find yourself way behind the time. So really, as a practitioner, I'm a big fan of kind of paying attention. I've been burned plenty of times getting so far out ahead of the curve. There's a lot of materials and a lot of things that I've tried that were just, for me, a disaster, didn't work at all. So at this point in my career, I'm pretty judicious about what I'm willing to change and not, and it has to be some very specific reasons. When I think about dental instruments, and again, our profession, if you think back, early 1900s, really, this is kind of what was there. A lot of hand instrumentation, had a rotary belt system for a latch speed, slow speed handpiece. And if we look at kind of where we are today, okay, the basic instrumentation kit hasn't changed. We've gone to either a pneumatic or an electric handpiece, which is dramatically better. I'm a huge electric guy, have been for probably 25 years. And if you haven't tried electric handpieces, I would highly recommend it. But again, a lot of it's, we haven't had a lot of huge jumps outside of like in ortho. I mean, there's been some challenges for us. We've been kind of stuck in some old modes and kind of working through some of that. If I think about, traditional dentistry and how it's taught in dental schools and how we were all kind of originally trained, and I'm going to pick one quick topic here. And that is, if we're going to do an indirect restoration, whether it's a crown or an inlay or anything along those lines, we basically fall back on a process called the lost wax technique. Lost wax technique was developed in China, probably about 1,000 years BC. So, if you think about it, if we're doing impressions, pouring them up in a model, waxing it up, investing the wax, burning that out, casting something, that's a lost wax technique. And so, it's a 3,000-year-old technique. Now, obviously, we don't use sand and stuff like they did back then, but still, it's based on that same premise. There hasn't been a lot of fundamental changes in that for a long, long time. I kind of consider this kind of the analog phase, if we want to think about it. It works fine. There's a lot of drawbacks to it. There's a lot of stuff going on in this cycle, and we've all been through it of, prepping impressions, models, waxing, until you finally get to delivery. And one of the things that I think about of this, and again, I typically, look at industry a lot, and I do a lot of industrial comparisons. And I always think about, this works well, certainly, and still a lot of people still do this process today. And, it functions. There's, some big time drawbacks with it, but still it's just a simple thing that everybody's used to. I kind of connotate that to a company called Kodak, which was around for 125 years. And basically forever, they owned the film market. If you were taking a picture somewhere, you were using Kodak film. What a lot of people don't realize is Kodak in their research actually are the first ones that developed the digital imaging patents. So all the original digital images, which is obviously what you do on your phone and cameras and everything today, Kodak was the one that invented that and patented that. So they looked at it and said, this is contra to our film business. And so we don't think that we're going to follow the digital path because it's going to take away from our film business. So today, when you think about Kodak, most people don't have any Kodak products. They're still in existence, doing some really kind of niche stuff for industry. They're really not in the consumer business anymore and totally a shell of themselves. So again, just a comparison of more of a traditional dentistry thing to a company that really didn't stay up with the times, but had the ability and the knowledge and just chose not to follow that path. Compare that to CAD/CAM dentistry, which again is what I do day in and day out, where there's no impressions, there's no temporaries, the patient doesn't come back. I scan, I design, I mill, I place that day. This morning is a prime example. I had a patient fly in from New York that I had placed an implant in. Took the healing cap out of the implant, scanned the implant body and 2 crowns behind that. Put that healing cap back in. Say, hey, go get a Starbucks. We'll see you in about an hour and a half. He leaves. I design, mill out both the implant crown, which was out of Emax, screw retained, and 2 katana, which is zirconia crowns behind it. Patient came back in, took me about 15 minutes to seat him, adjust the bite, and he was done. And really wasn't any a bite adjustment, but I always kind of check that. Well, that's the kind of stuff that you can do today. I mean, again, that's readily available. I do it every day, day in and day out. And patients come, like I said, this guy travels from New York to come to me for me to take care of it because he just wants that level of service. I kind of think about CAD/CAM dentistry the way, and Apple is an example. I mean, they were probably the first company that actually crossed the $3 trillion valuation. They're back down below that now, but massive value in a company based on a digital realm. And I think our profession certainly needs to move that way and is moving that way. If we think about digital x-rays, the vast majority of us, I would hope all of us would be using, a digital PA or whatever instead of film, which the bulk of people are. But, move that forward into, again, the CAD/CAM, the CBCT. That's really, kind of where it's at. I can't tell you how many patients, whenever I do these, are just amazed that, crown, root canal, everything's done in one visit. They don't have to come back. And so they, whenever a lot of them, I used to have my mills when I was milling these back in my lab, but I actually brought them out and created a little area with some chairs where patients could sit and watch their crown being made. And I can't tell you how many of them get their phone out and take pictures of it because they're like, oh man, I can't, so-and-so said I wasn't going to get my crown today. And I was just telling them that I was. So again, just an example. And this is just one of many examples we can talk about of how kind of moving into the digital age or disruptive technology or disruption can occur in a very positive way. I mean, certainly disruption can occur in a negative way, but if we kind of judiciously think through it, I think we can come up with processes and protocols that really benefit you and your practice, and more importantly, your patients. So the next, 30 minutes or so, we're going to talk about, class 2s, pretty straightforward, whether it's replacement restorations, like in this case, or whether it's just, getting rid of some decay or for whatever reason that you're doing class 2s. Composite restorations. In fact, the last case that I did about an hour and a half ago was a MO on tooth number 1. Not my favorite thing in the world to do, but that's what, the patient had some decay, so that's what we did. Composite materials like that are a highly needed service, but at the same time, they require a lot of time and effort, and really on a cost issue as far as the amount of time that you put into it for the revenue that you generate. They're not the greatest in the world. I mean, you can do a lot of other things that have a much higher value as far as, your valuable time for you than composite. So the better that we can do these and the more efficiently we can do these, and, the better it is for everybody. So over the years, I've tried out, everything, and I say everything that I'm aware of. And I'm going to share with you what I do today and have done for the last several years routinely for all of my posterior composites. If we think about a posterior restoration, in this case, a class 2, we're going to remove an amalgam and place, a composite. Now, this composite here is about 5 years old, and you can see, it's really a good restoration, but a little dull, kind of lost a little bit of its luster, but still very functional, works great. That's the kind of restoration that we want to be able to do routinely without post-operative sensitivity or people having problems with it. So if we think about posterior composite restorations, what are we looking for? Well, today people they want something that looks like a tooth. They don't want a hunk of metal, or they don't want something black or gold or whatever. They want it to look like a tooth. That's kind of the standard that our society's kind of come to. It needs to seal the tooth. We don't want it to leak. We don't want them to have post-operative sensitivity. We want them to be able to eat. We don't want it to break. And we don't want to, like the old GV Black, where we used to extension for prevention, where we have to go rip up a bunch of tooth structure just to get some mechanical retained or to get rid of some little groove because something's going to come there. We want to go in and remove the least amount of tooth structure. I'm not a big fan of amputating teeth, so I'm a huge fan of what the minimal amount is that gets the job done. And with our materials today, we can do that, which, for a long time we couldn't. If you think about composites, and, for a long time, they're like, oh, they're just not as good as the amalgams, and, they just don't last as long. And so, again, I'm geeky enough to kind of Journal of Adhesive Dentistry, 2012, meta-analysis is where you go out and you don't actually create a study yourself. You look at all the studies that are out there that would apply to what you're trying to understand. You go through and create a criteria for your analysis. And so in this particular case, they looked at 373 clinical studies, 59 met their inclusion. And out of that, what they found was that the composite success rate at 10 years was 90%, which is no different at all from that of amalgam. Now, again, this is not going back to, when I had my first composite put in me, which was, an old P10 back in dental school, 3M P10. I'm talking about, recently, like in the last, say, 15 years or so. So composites have come a long, long way. They're really the standard of care today. So the challenges on especially posterior ones are, predictable contacts, especially if we're going to be, interproximal at all. Occlusal is one thing, or a buccal or lingual, but if we're going to be interproximal, we need to make sure we have, not food traps. We need to get our contacts right. Certainly don't want any post-operative sensitivity issues. And we want, placement. We were trained and taught, hey, layering. Now today, most people do some kind of flowable with, a restorative composite on top, or we'll get into bulk fills, and we'll talk about all that so everybody can kind of see kind of where it's come from. So solutions for these challenges, matrices, everything from Toffelmeyer's, which, kind of old, but some of the segmented matrices that we use today, really there's no reason why you can't get a really, really good contact. Post-operative sensitivity, adhesion is the key there. And man, I've got, I can spend a whole day talking about adhesion, because that's really the key to any kind of composite, anything, as far as, what works and what doesn't and why. Really, really understand your adhesion, and whatever agents that you're currently using, just really make sure you've got that down cold. So as far as lining and layering, placement time and effort, you need specific materials just for that. If you think about current techniques, we're going to go through and isolate. We're going to, isolate the tooth, remove whatever decay or existing restoration. We're going to select and place in our matrix. We're going to go through our adhesive steps. Again, really, I can't be overemphasize how important it is to get that right. And then today, typically place a flowable or resin ionomer liner, and then you're going to place and adapt, some type of restorative composite, two to four increments. You're going to adjust the occlusion, finish, and polish. So if we were going to create a new material, what would we want? Something that's going to reduce layers, which is going to reduce the effort, reduce the time, and increase the profitability of you placing this thing. That's really kind of the bottom line. I use today Sonic Fill and I started out with Sonic Fill originally. It went through Sonic Fill 2, and now it's in the Sonic Fill 3. Of all the systems that I've used, this one works the best. And we're going to go through why. There's a lot of different ones that you can try, but for me, in my hands, this one is the cat's meow. It just does it. So today, instead of incremental, really everybody's gone to some kind of bulk fill, whether it's a flowable or a restorative. And here's just a, kind of a partial list. This is by no means inclusive. If what you're using is not on here, don't say, oh, well, he didn't know about this one. Yeah, I pretty much know about all of them. But I just, this is just a quick sampling of flowables and a quick sampling of restorative composites that that are out there and available, and most people are using some of these or combinations. If we talk about the flowables first, again, SureFill's a good one. If you're going to use a bulk flowable, then what you're going to do is you're going to place a pretty big flowable resin base in, and then you're going to come back and do your enamel replacement. Or your composite, your restorative composites on top, a couple of layers there. Adaptation is going to be great because the flowable is really going to fill in all the nooks and crannies way down in here. So you're going to get adaptation of the material great. Strength's not going to be as great because, again, the capping layers are only where the strength is. Flowables don't really have a great ability for strength and or abrasion or wear. If we talk about the high viscosity restorative stuff, let's just think about viscosity real quick. High viscosity is going to be decreased wettability. Low viscosity is increased. Surface tension basically is what you're talking about. So when two materials meet, the surface tension of the materials between each other is going to tell you whether or not it's going to flow or not, basically. And the term that's used is a high contact angle versus real low viscosity one's going to have a low contact angle. Basic physics, nothing crazy there. What that means is that if we're going to do a restorative and we've got some microscopic restorative enamel or dentin that we're trying to flow or get material down into, a high viscosity material is not going to work as well because it's going to have a high contact angle. It's not going to be wettable enough to really flow down in there. So that's when we get into our low viscosity stuff or our flowables. They actually flow into those little nooks and grooves, and that's really what we want. So we want something that adapts real well, but we also want something that has the strength and durability. Again, some other studies, I'll be quoting them as we go through here just to let you know I'm not making this stuff up, that I actually, pay a little bit of attention to it. So some of the bulk fill high, viscosity restorative materials. Again, Tetric's a good one. You can, again, you're going to put some little bit of liner because it doesn't flow around and you're going to want your adaptation really well. And then you're going to just fill the rest of it up. You're going to need at least no deeper than, say, 4.5 millimeters because of curing depths of those. And again, you put your flowable in, cure that, and then come back and put your bulk fill on top of it. The increased strength is great because, again, you're getting a true restorative for the majority of it. But adaptation's low because you got to have a liner, and the liner's not going to go everywhere. So what we really are after is something that's quick, one increment bulk fill placement. We want one layer, top to bottom, dentin and enamel all at the same time. It's got to have a high depth of cure, right? Because we always want to put it in and zap it one time and be done with it. Not much shrinkage stress, and shrinkage stress today in composites, you're going to really kind of decline to a little bit of nothing, but they're still there. The original composites way back when, those suckers used to shrink like crazy. So you would place just an occlusal composite, cure it, and then patient would come back with pain because as the material shrank, it would actually pull In this case, it would pull the two cusp tips toward each other, create a lot of internal stress because of the amount of shrinkage that would occur. You take a burr and kind of relieve the stress by cutting right down the middle of the composite, it would relieve the stress. They would feel better. We don't have quite that much shrinkage today, but you still have a little bit. But you want the least amount of shrinkage stress in these materials as you can get. Increased mechanical properties, obviously adaptation's big, and you want it to look like a tooth. The Sonic Fill 3, again, the way that it works is it has to have a specific handpiece. No big deal. Sonic energy is applied to the material through the handpiece, and that's how that's how it works out. So you get a true single fill increment, no liners or capping, and it just, it works extremely well. So what happens is you take the material, which is in your compule here. It starts out as a highly filled, high viscosity restorative composite. You push down on your rheostat. It applies sonic energy through the handpiece itself, which basically creates a low viscosity, a flowable. You fill the material, the filling up. You take your foot off of the pedal, and it reverts back to a higher viscosity. So you basically kind of get the best of both worlds. You're going to end up with a high viscosity press sculpt, normal composite, but while you're placing it, it's going to act like a flowable. So it's going to get great adaptation, and then you're still going to get the polishability and durability of what you want, what you're used to. So adaptation, if we think about taking out again, class 2 amalgam, you can see the liner down in here that was placed. We're going to remove it. This is 42 months post-op, and you can see how well that this fills in. So you go, well, how does the sonic energy do that? How does that work? The best example of sonic energy that every one of you is familiar with is what I'm going to show you here. When we actually pour a model up, this vibrating, pad basically is creating sonic energy within the material. The bubbles come out. The sonic energy basically is shaking things around. When we want it to flow, we place it on there, and as you can see, the sonic energy will allow the material to flow. We're all very, very familiar with, or should be very, very familiar with, this utilization of sonic energy. So basically, we're taking that and applying it to a composite. So what we end up with is, again, a material that kind of matches the flowables and the restorative. The sonic fill does both. So it really, cuts down on the amount of time and effort that you have to use in order to accomplish that. So how much shrinkage, stress, and depth of cure, which will be two things that I always kind of come up with. Well, if you're gonna fill this whole big thing at one time, how much curing do I need to do, and how much shrinkage am I going to get? Because that's really going to be the make it or break it. So the way that this works is, and I'm going to get into a little geeky here in Hooke's Law and stuff just for a second, just so you can have a better feel for it. The vibration energy that we're going to apply to the material is basically going to cause a liquefaction process where you get your flowable, and then when the energy is removed, we're going to go back to more of a solid state. So if you think about it, and again, I know geeky graphs, I got it. But if we activate, we push down on the pedal, basically the shear stress gets dramatically reduced by 87%. Okay, so viscosity is going to go, it gets flowable in a hurry. We take our foot off, it immediately recovers back, and now we can go in and sculpt it and create, whatever we want before we cure it. Other composites, because I thought, well, gosh, why don't I just take the composite that I'm using now, place it in there, take my ultrasonic or scalar, stick it in the middle of it, and push down. So I'm creating sonic energy within the material, just the normal material. And really, which I understand, I mean, that makes sense, but regular composites, because they're not built, in a almost like a ball fashion, like sonic fill is, the physics just don't allow it to create that level or create that level of viscosity drop. So you do get some, but nothing like what you do with the material that was designed for that. So the modulus of elasticity, when you cure it, goes down. Hooke's law again. When you decrease shrinkage and decrease the modulus of elasticity, you're also going to decrease stress. So that's where you get, a really great complete fill without really a very, very little bit of shrinkage material. This is a ADA way back in 13 when Sonic Fill, the original, came out, and you can see mean polymerization shrinkage stress in megapascal. So you can see kind of the standard ones that you're, may or may not be placing in there today, but because of the way that it's placed, the shrink stress, and again, this is Sonic Fill. We're on Sonic Fill 3, 2 generations after this one, is even, dramatically less than this. So it really makes a big difference when you get into Hooke's law and all this other stuff. I'm not going to bore you all with any more than that because it's too late and everybody's tired. So let's not get into physics. Let's just keep it simple. So how deep can we cure this stuff, right? Control, which is Filtech Supreme, you've got about a 3 millimeter depth of cure with a real high intensity LED, 100 milliwatt per square centimeter worth of per square millimeter worth of light control. You get about 3 millimeters. This is out of a clinician's report back in 2012. But Dentsply, SureFill, Venus, and then Sonic Fill, they were getting 6 millimeters, which is dramatically, a really, really good depth of cure with that material. I use it for class 1s, class 2s, obviously core buildups, and even class 5s. I also, on my, aligned ortho aligners that we use, what I do is I take the Sonic Fill while I'm going to place attachments and use the Sonic Fill to fill the little attachment piece up, cover it so that it doesn't cure before the patient. And then when the patient gets there, I take a little bit of flow and just put it on the face or on the back of the Sonic Fill, and then, etch and prep everything, put it in place and then cure it. That works beautifully. I don't have any voids. Everything is just great. So another thing that I use the Sonic Fill for. Research, there's tons out there. And again, I'm not going to bug you a bunch. Basically, conclusions of these things is that Sonic Fill's bonds are, equal to, if not better than a lot of the composites that you're currently using. Again, more geeky stuff. As far as abstracts from different things, this was done at Queen's University in Belfast. Again, bottom line is that you had fewer gaps and seams with the bulk fill, the Sonic Fill material, instead of if you were just doing it by hand, which would make complete sense. So it's a rapid, simplified technique. It works off of a multi-flex coupler. The handpiece does. I keep it on my unit all the time, basically. So if you've got any kind of, air-driven handpiece, this coupler screws into that. You fit your handpiece onto that, and then you're ready to go. That's all it is to it. When you push the rheostat, the energy's generated in here, which again then causes the material to liquefy and come out. You actually place the compule in and it's screwed on because, again, the amount of force that's being applied here is pretty dramatic. So if you didn't have it screwed on there and you push the pedal, it would probably just pop right off the end. There is settings on it for speed. They have 1 through 5. I'll be honest with you. I keep mine at 5. I never change that. I just change the amount of flow that's coming out, basically with the rheostat. If you notice the normal cannula that you would have or opening that you would have in a normal composite is fairly big in comparison to this, simply because, again, you're pushing a bulk, pretty high viscosity material out, so you have to have a big enough opening that it will come out for you. Sonic Fill has a much, much smaller opening, again, because we're actually going to create kind of a flowable, and so you can get away with that. So if we go through the process here real quick, if I'm going to take an amalgam out and put one in, this is 44, right at, not quite, almost 5 years later with Sonic Fill. The original, again, you can see I'm not real thrilled with the luster here, the Sonic Fill 3, which I'll show you in a second. All this has improved, but again, durable, works well. And so I'm going to work through this process with you pretty quickly. Adhesion bonding, let's talk about that, because if you don't get this part of it right, it doesn't matter what you're using from that point on, you're going to have problems. And again, I wish I had another couple of hours just to talk to you about adhesion, because I think a lot of people are having, if they have mistakes or problems or pain or failures, it's going to be in their bonding really more than the composites themselves. If you think about bonding, what we're trying to do in dentistry is, we've got two dissimilar materials. We've got enamel and we've got dentin. One's organic, that's got a bunch of fluid and enzymes that are trying to do all kinds of things. The other one's 98% inorganic, real simple to bond to. This is easy to bond to. This is hard to bond to. So big differences in the two. Really pay attention to whatever you're bonding that you're using. And again, whatever system that you're using, really pay attention to it, because again, that's going to be the basis for all of it. I am a huge, if you look at etches, you can do total etch, self-etch, or selective etch. Total etch is what we did to begin with, where we etched dentin, enamel, everything. We would wash all that off, place our adhesives, and then kind of go from there. We went to kind of a selective etch, and then again today everything's self-etch, where universal adhesives, you don't even need the etch anymore, just the etchant's built into the adhesive. I'm a huge selective etch guy. If I'm going to bond to anything, I'm always going to selectively etch the enamel, because you're going to improve bond strengths anywhere from 10 to 15% just by selectively etching. So again, whether you're using a universal, which is great, but I still selectively etch enamel, and you don't want to, etch the dentin and enamel. If you're going to use a universal, you could end up, with problems with that. Here's the geek in me again. This is a study that was done several years ago, never really published. This was more for a lab, kind of a chemistry kind of a presentation done in kind of a white paper. And again, they were just talking about bond strengths of different, for both dentin and enamel using self-etch and total etch. And really the thing that jumped out to me is that, the total etch is obviously where we etch dentin and enamel. Self-etch is where you don't take any phosphoric acid and etch anything. This is just what you, with the universals adhesives, just apply it on there. But the point being made, and again, this is not what this paper was designed to do, but if you look at the differences, so if you etch dentin, so here's dentin that you're just going to apply your material on without any etching. If you etch dentin, you're always going to lose bond strength. If you etch enamel, selectively etch enamel, using some of these universal systems, you're always going to improve it. So enamel gets better, dentin gets worse. Dentin gets worse, enamel gets better on all the material. So in material, what you're using over here, selectively etching the enamel is always going to improve your bond strength, regardless. If you happen to etch dentin on top of it, you're going to lose or decrease your bond strength to dentin. So that's it. Like I said, I could spend days on it, but I'm not going to, mess with it any longer than that. We're kind of running out of time. So the first thing you want to be absolutely sure you do is you place your adhesive on, you blow it down, you dry it. You don't want any solvents or anything moving. Okay. And it doesn't matter whether you're a 2-bond guy or 2-bottle or 1-bottle. Just make sure that what you want before you try to apply anything is this. You want really glossy dentin. You want it to shine. You don't want any kind of dull, you want a high luster on this dentin before you go forward. If you don't have that, you go back and reapply. And do not move forward until you have glossy dentin. 5 millimeters, basically 5 or 6 is what we're going to use as our depth on the sonic fill. There was a study done in, again, Scandinavia, that the majority of cavities are less than 5 millimeters in depth. So here's how it's going to work. This is typically what it's going to look like. Okay, so what's happened there is, as you can see, it fills from the bottom. The energy's placed. It's put on, and completely fills the thing up without any voids or gaps along those lines. So big difference. I mean, I would highly, again, this is something that I would certainly that I use all the time. We've talked about the tip size and how that helps. So the way I would do this filling is I would go down into the proximal box at the gingiva, start filling there. I would come up across. Once that was filled, I would take and sculpt it, shape it, cure it with a high output, again, at least 1,000 milliwatt per square centimeter light for at least 10 seconds. I would then take off my band, clean up any flash, however you're going to do that. Adjust it if I'm going to, again, flash-wise. Come back and cure it 10 seconds on the buccal, 10 seconds on the lingual, 10 seconds on the occlusal. So I've got a total of 40 seconds worth of cure. The 10 that I did before I took the band off, and then another 30, and I'm done. I'm going to then come back, take the rubber dam off. If I've got a rubber dam, I'm going to check my occlusion, adjust that. I'm going to come back. I really like the Pro Gloss system, polish it up. And again, this is a 5-year post-op. You can see how well it's maintained itself. Again, I'm not thrilled with the luster, but that's Sonic Fill, and the Sonic Fill 3 has resolved that for me. You can see how well the adaptation was. This is where I'm at today with the Sonic Fill 3. Improved durability, polishability, working time, and overall aesthetics are great. You can see how the luster now on one that's been in, I think this one's probably 3.5 years, how well that the luster has maintained in comparison to the original Sonic Fill. If I'm going to do a bigger composite, in other words, an MOD, I'm going to start in one box. I'm going to move to the occlusal. I'm going to come out. I'm going to go back into the other box and then kind of tag team the two in the middle. So I'm going to get a really good fill throughout and have that nice and sealed up. If I'm going to do posteriors, again, that are greater than 5 millimeters, say I'm doing a buildup and I want a 4 millimeter, 360-degree ferrule all the way around. So I've got 2 millimeters worth of tooth here. So if I'm going to it's a 7 millimeter depth. So 7 plus 2 is going to give me 9. So I need 9 millimeters worth of total buildup material here to get where I want to be. I'm going to place my adhesive and cure. I'm going to put my 5 millimeters in, compact that. I'm going to cure that. And then I'm going to come back and add another 5 millimeters and cure that. And then prep that down so that I can get, again, this is kind of more of a traditional 360-degree ferrule, 6 to 8 degree taper on it to get a, that kind of prep. So this is how good the fill is. I did not do this. This was done by the endodontist. I was just doing the restorative aspect, so don't point fingers at me at that. That always bugged me. So, this is pretty typical stuff for me. Patients on the schedule, hey, Mrs. Jones is coming in, re-cement a crown. So she comes in, well, the crown, the buildup, the whole thing's come off. It's like, yeah, that's not a 5-minute re-cement. This is kind of a real big problem. So for me, I take my Sonic film, I build it back up, re-prep it, I scan it, mill out this was an Emax crown, and so probably in about 60 minutes, instead of me re-cementing a crown, I had done a new build-up and a brand new crown. And that's, again, just kind of a day-to-day process for me. This is, again, is another case where patient came in, re-cement crown. Yeah, she comes in with the crown in her hand. Obviously, the tooth had broken off. So we did a root canal, did a post and core buildup, Sonic fill, and then replaced the crown. Again, that was about an 1.5 hour process, but it went from just a re-cemented crown to a complete, overhaul. About 4 years later, the patient's back on the schedule, re-cement crown. I'm thinking, oh my gosh, it's something that, that came off. Nope, it was the other one that broke. She came back over, and obviously we did the same exact thing a second time. So some of the things that you can get into, some of the problems, if you get kind of crazy with it, not paying attention, you can certainly, don't do that. You're going to create a lot of voids and problems where you will end up with post-operative sensitive, you will end up with leakage, and you will end up with problems. So, really pay attention. If you don't press the rheostat all the way down where you're getting a solid fill, again, you can end up with some voids. Just stuff to pay attention to. Doing it right, start in the box, depress, come up, go all the way across, boom, you're done. That's how long it takes me to do a filling. And that's the kind of result that I get every time. I'm going to show you this real quick. This is probably one of my favorites. We're about ready to wrap it up here. But again, when I think about, I go back to lost wax versus, digital versus analog, lost wax versus CAD CAM. When I think about the way I used to place composites versus the way I place composites today, this is probably one of my favorite examples. I'm going to show you this. This is Formula One pit stop. So let's just watch and listen here real quick.
But Holland comes in for a pit stop. Time to refuel and change tires. Lou Moore himself changes the tires. Only 4 crew members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch.
So you got 4 guys changing 2 tires and putting gas in, and actually washing the windshield at the same time, which I think is kind of fun.
The tires are changed at last. A crewman polishes the windshield as Holland moves away just 67 seconds after he stopped.
Okay, so 67-second pit stop. Now this is Formula One 2013, Team Ferrari, Melbourne. I always love that. I mean, that's just great. We had 22 guys, about 3 seconds. I didn't show you any of the ones that are more recent because they're even faster than that today. But, think about it. How are you putting composites in? Are you doing it, more standard, or are you kind of getting with the program and getting them in there pretty quick? Just to kind of wrap it up, sonic fill's not for everything. Like this is a class 5. I'm not a big fan of this. I mean, I think today with some of the more universal composites, Simply Shade or some of those, I think you'll do a lot better job than what sonic fill would here. Another one where it's not probably a good idea, if you're really after color, sonic fill only comes in like 5 shades. And so again, it fits great. But again, because of that, you're not going to get quite the translucency that you would with a Simply Shade or one of those. So I'm going to wrap up with some pointers. These are the best pointers that I know of that I'm going to leave you with. And that's this. I'm a big upland bird guy. And so this is me and my buddy Jay in a perfect pheasant field, lots of snow, and some of the best dogs I've ever been around. So those are my pointers for the day. We're going to get to some questions and answers now. Corinne's got some questions, I think, that she's going to roll out there. And then I'm going to leave my contact slide here. So if you need to get in touch with me, if I don't get to your question, don't hesitate to track me down this way, either website or email or phone.
Thanks, Dr. Coleman. I loved your pointers. Just a reminder, everyone, we are opening up the Q&A, so you can submit the questions under the Have a Question box. We do have a question to start us off from Nick, who asks, what do you do if you get an overhang? Does it come off with interproximal strips?
Yeah, so say your matrix or whatever didn't seal it like you wanted it to. It's no different than what you would use any other time. I mean, it's not like this stuff is harder or ends up being, more difficult to work with. It's really not. So if you have an overhang, then yeah, get in there with your interproximal polishing, or if you can get a fine diamond or whatever that you're going to get to that's going to work for you, move in with that and just work that down. Obviously, overhangs are built, based on how well your matrix is sealed. And so that's really the key. The composite itself it's going to go where the matrix is. And if the matrix not really tight, then yeah, it's going to flow out and create an overhang for you. Although I guess over the years, I really haven't run into that a bunch just because, I'm used to doing it and I want to make sure that I don't have to go and try to clean one up.
All right, great. I don't see any other questions coming through, which means you probably answered everything during your presentation, Dr. Coleman. Great job.
We're good. We're good. Well, I'm glad to help. And like I said, if you guys have any, this is a great way. That's my information to get in touch with me. If not, I hope you guys have a great night.
All right. Thank you, Dr. Coleman, for the excellent information tonight on tonight's webinar. And thank you to everyone for attending. I hope you enjoyed the webinar tonight. We would appreciate your feedback via our survey that will pop up on your screen shortly. We also did record tonight's webinar, so we will email the recording out via email sometime in the next week. And lastly, if you are interested in attending any future webinars, visit www.henryscheindental.com/webinars for our upcoming schedule. Thank you all for joining us, and we look forward to seeing you on future webinars. Thank you again, Dr. Coleman.
Oh, you bet. Thanks, Corinne. Good night.
Have a great night.